Good morning, everyone. Today's topic is about local anesthetic toxicity, and many of the slides are available in www.painfreepartha.com in the slides section, and most of the slides are also available in YouTube channel. Search Pain-Free Partha. Thank you once again for supporting me this YouTube channel, Pain-Free Partha. So, what is this local anesthetic systemic toxicity? So, there are certain things. First, number one is allergic reaction. A local anesthetic is given and it develops an allergic reaction to whatever its contents, for example, methylparaben or whatever its contents or lignocaine itself. Then it becomes an allergic reaction. Number two is if you give the drug into the tissues, the tissue can develop toxicity, for example, myotoxicity. So lignocaine, TENS, transient neurological symptoms, TNS. These are not last. You have to have systemic absorption, and this is what is called lust. Now, facts before the topic. True immunological reactions to local anesthetics are very rare. Preservative amides are very rare. Ester amides are only common. Ester local anesthetics are common because it is metabolized to PABA. Accidental intravenous injections are often misdiagnosed as allergic reactions. So they may develop allergy to methylparaben. So true immunological reactions to local anesthetics are rare, especially amide. Can happen with ester or can happen with methylparaben. Now in 1880, cocaine invented and toxicity is described then only. Now still it is going on, and 1979 Albright described last. Till we don't know many of the things about last. Now why are we worried now? Last now. In the 1990s and 2000, for a breast case, we just put the tube and take it out. For LSCS, cesarean section, we give spinal and injection for twinpenthrine or something like that and finish the case. Now we are not stopping with this. For a breast case, we give SAP block. For a breast case, we give paravertebral block. For a CABG case, sometimes we give bilateral paravertebral blocks. We give LSCS and this thing TAB blocks. So we use more. We use local anesthetics more. Probably we may get more of last. Now, what are the clinical scenario in which a loss can occur? Number one is unintended intravascular injection. Now, we are not intending to give this drug, the local anesthetic IV, lignocaine IV, but it goes off unintendedly into the vessels. This is one. Number two is fast absorption of an intended correct dose. We have given the correct dose of 2 milligram per kg only, but it has got fast absorption. For example, it depends upon the place. Intercostal is more. That is, I'm going to describe later. A fast absorption of an intended correct dose. A routine absorption of an excess dose. Unintentionally or some due to other causes, we have given 6 milligram per kg of Prilocaine. This is an excess dose, but it absorbs is a routine. All these things lead to lust. Now, what is the incidence? Some studies report 0 events, a few report 25 per 10,000. One study reports 79 per 10,000. Another study reports 1.8 per 1,000 or 2 per 1,000. This is a normal thing what we can have, around 2 or 1.5 per 1,000. What is the order of toxicity? Intercostal, caudal, epidural, brachial plexus, sciatic femoral, mepivacaine. This is intercostal. See the caudal, epidural. All these things were described in 2000 and before 1995. Now we have come across transtracheal, we have come across paracervical, and we have come across IVRA. So all these things are a little more. So transtracheal, intercostal, paracervical, caudal, epidural, brachial plexus, sciatic, and IVRA, and IV local anesthetics also can come in this. So now order of toxicity is more of transtracheal rather than the earlier described intercostal. Topical preparation like sprays, gels, liquids can also cause loss. See here, we spray local. See, most of the sometimes the urological procedures, they just pump in local anesthetics. We have given an epidural. They pump in local anesthetics in this thing to pass the catheter. So topical preparations also can cause loss. Tumescent anesthesia for cosmetic procedures. Previously it was described. Now if we have some post-burns contracture here, we are very apprehensive about the airway. So what we do is tumescent anesthesia. We take so much volume of local anesthetics along with ringer lactate and inject around 200-300 ml of anesthetic drugs, local anesthetics. So you may go sometimes to 35 milligram per kg. So tab block bilateral 0.5% ropivacaine each side. They have proved last as occurred. It is not about us. Sometimes it may be about inferior dental nerve blocks and retrobulbar blocks, sometimes paravertebral blocks, sometimes in catheters, especially if you are giving an infusions. The local anesthetic will stay there and increase the level of toxicity. IV local anesthetics. That is sometimes the neuropathic pain and all. They give daily IV xylocaine in the drip. So to cut down this neuropathic component of the pain, so that after giving the local anesthetics for 5-6 days, sometimes your pregabalin or gabapentin may act. So these are all the clinical scenarios. It is not that the patient is only under rest. Sometimes it may be under surgeon, sometimes it may be under dentist, or sometimes it may be under physicians giving paravertebral blocks. So sometimes it may be under the care of staff nurses, acute pain service nurses. Awake fiber optic intubation. So we give here, there, transtracheal local block. Sometimes after that the patient is coughing and give some more spray as he go, all these things. So here the fits may not occur because we have very well sedated the patient with 2-3 milligrams of midazolam. So convulsions may not occur. So that is the problem with awake fiber optic intubations. Physico pH is more uncharged form permeates into the cell. It doesn't stay in the circulation. More lipophilic molecules, more into the cell. Increased protein binding, decreased free plasma concentration. If you have less proteins, free plasma concentrations may be high. Ester hydrolysis, drug is given, hydrolyzed, then the plasma concentration will decrease. Or isomer binds avidly to cardiac cells. So these are all clues. That doesn't mean if you give a more lipophilic molecule, it will permeate into the cell and doesn't cause loss. Nothing like that. These are all clues. Okay, we have given this. The protein is high, so automatically protein binding decreases the systemic concentration. Now we have cocaine as the worst and 2-chloroprocaine as the least problematic. Now here you see what are the drugs we use. We use these three. Cocaine and tetracaine we don't use. Bupivacaine, L-bupivacaine, ropivacaine and lignocaine. Of class, lignocaine is least and bupivacaine is, this is the graph or the figure we should be keeping in the mind. Bupivacaine for us, lignocaine is least. L-bupivacaine and ropivacaine are next to next. Now what are the comorbid risk factors? If we have extremes of age, less than 2 or more than 75, the chances of loss is more. If we have a cardiac ischemia, now we have the drug is going to attach to the cardiac myocyte, which is already an ischemic, then there's a problem. If we have liver disease with protein decrease, if we have pregnancy, if we have an acidosis, if we have a frail patient, or sometimes a renal disease patients, all these things are comorbid risk factors, where a small increase in toxic dose may land up in a trouble. So we should also analyze if the patient is a frail, old age patient with an ischemic heart disease. All these things matters when you give the drug dosage in the intended site. Now, the cellular mechanisms of cardiotoxicity is not that the drug goes and blocks the sodium channel. It is not that. It is A, B, C, D, E, F, G, H, all these things. It can block the sodium channel. It can block the calcium here. It can block these beta receptors. That is why the beta blockers are not that effective. Here you can stimulate this potassium channel, or you can affect the ATP synthesis and affect the actual actin myosin coupling, or you can here the binding of calcium is also blocked. Here the ryanodine receptor is blocked. Here the calcium is blocked inside also and outside also. There are so many mechanisms. It is not that the sodium channel is blocked. ATP, calcium, this calcium, that calcium, adenylyl cyclase and beta receptor, potassium. Here you can see the CAMP, CAMP. All these things may be affected in a patient who is being given bupivacaine higher doses. Now the CC is to CNS. CC is cardiovascular collapse. CNS is switch or something. It is 2 for lignocaine and it is 7.1 for bupivacaine. If it is little low, means they are little safer. Usually the local anesthetic causes serious symptoms only after 3 times the concentration of CNS. But racemic bupivacaine and etidocaine may be exceptions. This is the toxic dose. Lignocaine 3 and epinephrine 7. It does not change much with bupivacaine. That is very important here because they are not basically vasodilators. This is a vasodilator. If you add adrenaline, yes, it may help. But this bupivacaine is not acting much on the vessels. So your addition of adrenaline may not help much. Myocardial depression, decreased contractility, and chances of rhythm disturbances. All these things are there, and convulsions may be caused by the blockade of GABA A receptor in the CNS. Sometimes, see here, it is only the symptomatology. It starts with numbness, lightheadedness, visual disturbance, twitching. Patient goes into fits and unconsciousness, develops respiratory arrest, then goes into severe depression. That is what we told. The CNS is more likely to get than cardiovascular depression. Severe symptomatology will change with onset. For example, if you get seizures first, the seizure will induce the sympathetic surge. The patient can have BP rise, pulse rate rise, or it may have other autonomic disturbance in the form of pulse rate decrease followed by an increase. All these things can happen. It is actually not about direct cardiac depression. It is about a CNS toxicity of local anesthetic causing an indirect change in the cardiovascular system. It is not actually the bupivacaine induced cardiotoxicity. So severe symptomatology may change with what is the onset. If the onset is switched, then we can change changes here. Injection of lignocaine in the brain also can cause arrhythmias. So CNS depression for hypotension and rhythm disturbance. Hypercarbia, acidosis can dangerous. So all these things should not be there. Already we have told acidosis is a risk factor. Frail patient is a risk factor. Both viscera are very sensitive to anaerobic metabolism and both are very active in terms of sodium channel moving because only the active channels, the bupivacaine will go or the lignocaine will go and enter. So these are all one of the suggested reasons. We get seizures only in 35%, CVS only maybe in 25%, and seizures plus CVS and others. This is about the possible affection of which system, because seizures only and seizures here 65% account for the CNS. You need to have vigilance. The last symptom can start in 50 seconds or it can come even after 25 minutes. The 50% occurred in the first 10 minutes. You have given the block. 15 minutes later, you are going for the cup of coffee. Yes, they can have lost. This is what extreme vigilance is needed even up to 25 to 30 minutes. What is fast in and fast out? Lignocaine. Fast in and slow out bupivacaine. For example, now in systole, the lignocaine will go out, go into the cell, and in diastole it comes out. But what happens in bupivacaine? It goes in during systole and problem caused, and then it doesn't come out fast in diastole. This is the difference between lignocaine and bupivacaine. That is why this lignocaine comes out. The toxicity, cardiac toxicity produced by bupivacaine is sometimes refractory to adrenaline because it is a fasting, slow out drug. Yes, I have already told age and extremes, addition, additives, the speed which you have directed, what drug you are using, concurrent illness like ischemia, liver disease, renal disease, what are the concurrent drugs you are using, where you are using, IVRA, intercostal or paracervical, tumescent is more towards, while your caudal brachial plexus or less towards. Yes, we already told, but beware of combinations. Just because you have added 10 ml of lignocaine and 10 ml of bupivacaine, it is not every drug has to have the toxic dose levels. So it is additive. We are moving towards safer molecules, chirality, isomerism, all these things. Isomerism in anesthesia is a different topic which I will post little later. So it has already changed a numbness of the mouth followed by visual disturbances, central nervous system, then goes into seizures, then goes into complete CNS inhibitions. Hypertension, hypotension, tachycardia. Yes, they can have prolonged PR, QTC prolonged and bundle branch losses. That is what is the principle. Yes, what I have understood, I have told myocardial depression and rhythm disturbances. What are the differential diagnoses of NAS? It can have vasovagal and they can have high spinal, they can have total spinal, they can have concomitant diseases. Yes, this patient is a known epileptic. We have given brachial plexus. The patient throws fits. Concomitant diseases. A high epinephrine dose can cause hypertension. The essence of management is the prevention. Ultrasound, yes. If we give ultrasound, we are sure that we are directly not in the vessel. But sometimes if you aspirate, the negative pressure created by us can collapse the vein. So it is not completely foolproof. Yes, it is foolproof. But another thing is we have come down on the dose. Previously, 15 years ago, I used to give 35 ml of or 30 ml for a supraclavicular plexus block. But now I'm come down to 15, 16 ml. So we have come down on the total dose, which definitely causes a definite decrease in the incidence of blast. Ultrasound is not foolproof yet. Check the dose of local and epinephrine. Effective doses in aliquots. Aliquots means give 3 ml, wait, give 4 ml, wait. Aspirate frequently and discard bloody locals. If you have already a blood vessel there and you are having some blood in the syringe, and we will be getting confused. Monitor cardiovascular and always keep an IV access. Talk with the patient. Stop injecting. That is very important prevention. Communicate with the patient. This is another important thing. Even though you are giving some procedural sedation, you are not going to make them unconscious. You are giving some fentanyl, some midazolam to put a brachial plexus block or whatever it is. Now you communicate with the patient. How are you feeling? How are you? What is your name? What is your brother doing? Something like that. Communicate with the patient. Negative aspiration because smoke will compress the vein. Hepatic and renal disease, beware. The reduced toxic potential of the tube pure left supports their use in those clinics. Risk of yes. Yes, we have some cardiac disease. We have something, then you definitely give ultrasound. You be careful about aspiration. You give in aliquots. You give an enantiomer which is less toxic. You are encountering a high risk case, a frail old age patient with a liver disease. Yes, think of these things. A better enantiomer, inaliquids, ultrasound. Airway and oxygenation is the management. Yes, initial seizures, give oxygen, beware, take hold of the airway. That is very important. In case the patient has got a BP and pulse drop, then we should intubate. Or if the patient is full stomach, even during an fits of 5 minutes or 6 minutes, then your full stomach is there, then we may need intubation. So these are all the two clinical indications of intubation in a patient with fits with last. Now we are giving diazepam 0.15 milligram per kg. This is the drug of choice, benzodiazepines. I am not very interested in midazolam because midazolam's dose of convulsions, my personal opinion is minimal. You have to give 5-6 milligrams. We practically don't use that. you may need to use of midazolam 5-6 milligrams minimum dose. Why? Diazepam 5 milligram dose is adequate to stop most of the seizures. Yes, the next drug is thiopentone. Benzodiazepines also decrease arrhythmias. If we have arrhythmias, then we can think of phenytoin. This phenytoin is an antiarrhythmic drug and also an anticonvulsant drug. Yes, we have got VPCs. We have got a fits. Start phenytoin also. Give diazepam and start phenytoin also. No xylocaine, because we know in VPC, ventricular premature contraction, lignocaine is indicated. In this case of last, already we are in problem because of lignocaine. So don't give lignocaine for a VPC because of the cardiac toxic potential of last. Already I have told this local anesthetic can also penetrate the beta blockers, beta receptors. Thio or propofol, if needed, intubate. Less doses because Thio itself is a myocardial depressant. Propofol can cause hypotension. Propofol shares its myocardial dysfunction with local anesthetics. Number one is people may think lipid is there. Instead of intralipid, we'll give propofol. No. That lipid amount in propofol is not enough. Number one. Number two, it can cause hypotension. Number three, it can share the myocardial dysfunction with local anesthetics and it can worsen the myocardial dysfunction. So now airway, breathing, circulation, 100% oxygen, ventilation. So vasopressin can cause pulmonary hemorrhage. Amiodarone is questionable. Adrenaline is acceptable in less doses. Then we may need to go into CPP if preliminary resuscitation fails. The attachment of bupivacaine to cardiac muscle cell is transient. So it is not going to attach for 1.5 days, 2 days. It is going to be there for a few hours. Tide over till the drug goes out. Even a femoral bypass, partial bypass is enough. Patient need not be given anesthesia. Get the machine and put femoral vein and femoral artery. Try a femoral bypass till the drug goes out. Why low dose adrenaline? Because in last smaller than usual doses, because it may interfere with afterload, it may interfere with lipid-based resuscitation, which we are going to come now. Intralipid, this is available 20%, 1.5 ml per kg over 1 minute, and in 70 kg patient, it is 2 ml per kg. Then you start an infusion of 0.25 ml per kg per minute. If the patient's hemodynamic stability is not come up, patient's BP has not come up from 70 to 96, then you start repeating after 10 minutes. Yes, we should do chest compressions if there is no pulse because it has to circulate. Lipid has to circulate to go into the myocardial cells, into the CNS cells, all these things. Can increase this 0.25 ml to 0.5. Maximum is 12 ml per kg, where some guidelines vary. So 20% lipid emulsion, 1.5 ml per kg over a period of 1 or 2 minutes, followed by 0.25 ml per kg minute of interlipid. Maximum, you can wait for a few 10 to 15 minutes. It doesn't come out a repeat dose of 1.5 ml per kg, maximum of 12 ml per kg. Start your chest compression to promote the lipid to go into circulation. Yes, it is available. Long chain triglycerides and medium chain triglycerides. The mixture is better in improving systolic function. So LCT, MCT, long chain triglycerides, medium chain triglycerides. The mixture is better. So what are the mechanisms? Now we know the mechanisms you should be very careful here. The mechanism of local anesthetic toxicity is sodium inhibition, calcium inhibition, ATP inhibition, calcium inside inhibition, actin myosin decoupling, potassium stimulation. All these things are there, but your intralipid is not going to do all these things. It is not going to revert all those things. It is going to take up your local anesthetic molecule, which is lipophilic, and keep it like this. This is called the sink theory. There is a shuttle theory. Sink theory is keeping. Shuttle theory is taking out from myocardial cell and pushing it to the liver. Taking out from myocardial cell and pushing it into the fat or a skeletal muscle. This is what is called the shuttle theory, and this is better than the sink theory. Now you see the lipid emulsion is local anesthetic. It is there sitting here and removing here and keep it in this. It is not going to act on the cardiac action potential. Your intralipid. Your intralipid is going to catch your bupivacaine and push it somewhere else from the heart. There are a lot of other causes, like it may cause some benefit in nitric oxide release inhibition so that the vasodilatation is decreased. So these are all some of the causes. This is the main this is some of the rare mechanisms. Now if you see bupivacaine 10 milligram per kg, and if you give saline, the mortality fraction is in 15 milligram with intralipid emulsion. So we have proved that ILE is safer in reversing, is effective in reversing the bupivacaine cardiac toxicity. Predominant CNS changes give diazepam plus phenytoin. Predominant CVS changes go for intralipid. More lipid soluble is bupivacaine, so intralipid works well. What are the adverse effects of intralipid? We are not bothered about this intralipid emulsion adverse effects because these are more common with patients undergoing parenteral nutrition, not with this last reversal. So all these things like hyperlipidemia, immunomodulation, hypercoagulability, venous thrombosis are there, but most of these are associated with long-term parenteral nutrition. So what I feel is we should be waiting for laboratory analysis. As soon as you give intralipid, don't take any test so that it will confuse. When to start ILE? ILE is not the last resort. Initiate early in hemodynamic instability. If you are giving your bupivacaine and your pulse rate is less, BP is coming down, yes, give intralipid. Better results. Before adrenaline is also okay. So when to stop? 10 minutes after complete hemodynamic stability. Now you have reached BP is 110/70, pulse rate is 84. Wait for 10 minutes. Yes, it is maintaining. Then you stop your lipid emulsion infusion. It is not the panacea. Yes, we have got intralipid. We can give anything like that. We can give 40 milligram per kg, 4 milligram per kg, 5, nothing like that. It is not the panacea. If the underlying cardiac function is poor, if there is some coronary occlusion, there are some dangers. So, refractory to treatment, consider ECMO or bypass. Dexmedetomidine reduces the cardiotoxicity caused by bupivacaine, but it is all very preliminary. We should not be concentrating on this. Now, the last caused by lignocaine, bupivacaine, ropivacaine, L-bupivacaine is okay. But caused by Prilocaine, it is different because it may be associated with otolidine and with hemoglobinemia. So we may need to give IV methylene blue in patients who have produced loss due to Prilocaine. Now you see signs of severe toxicity: convulsions, cardiovascular collapse, conduction block, asystole. Yes, call for help, maintain airway, 100% oxygen, acidosis, correct, start an intravenous access, give diazepam or sometimes thiopentone and propofol, give and put the tube if you think the patient is full stomach or if you think associated fits has caused severe hemodynamic disturbance. In circulatory arrest, starts intralipid. Without circulatory arrest, even in case of hypotension, consider ILE. So then this is what is the follow-up of the patients. Usually if you are given everything pakka, they become normal because they don't have a basic disease. You are given IV local anesthetic. It has caused toxicity. You have given intralipid and recovered. The patient are not going to have problems later. Even trigger point injections. I have seen cases. I have seen a few cases where I have given local anesthetic, patient developed fits when I gave diazepam, and then patient settled. I was about to put the tube, but patient became normal. Then after 10 minutes, pulse BP was okay. I told the surgeon to proceed with the radius fracture, and after some time, the patient consciousness calmed back in, and patient was fine. Even OPD, I have given trigger point injections of 2 ml of lignocaine, patient develops fits. I have seen cases. So even in trigger point injections, yes, we should be aware. What is the summary? Yes, intercostal, but also IVRA, IVA for neuropathic pain, tumors and anesthesia, we should think. Paracervical and paratracheal, yes. Toxic doses doesn't vary with epinephrine in bupivacaine and ropivacaine. It is matters only with lignocaine. Which local anesthetic we are giving? Bupivacaine, lipophilic or not? What are the symptoms and differential diagnosis? Yes, we can have concomitant diseases. We can have other vasovagal phenomena. Prevention, yes, I already told ultrasound, dose, aliquots, where we are giving, consider frailty, consider the dose, check the dose, all these things. Treatment, yes, fits diazepam. Then you go hemodynamic instability, put the tube and start intralipid early. 20% lipid emulsion, 1.5 ml per kg, followed by 0.25 ml per kg per minute. Start early and finish after 10 minutes after hemodynamic stability. So anticonvulsants, phenytoin, when you have a patient with VPC, ventricular premature beat arrhythmias, and fits. Lot of case reports and animal studies. There are no big human trials and findings so far. Now, which regional technique is the safest when you are contemplating last spine? Thank you all.